Hi there, welcome to The White Side of the Brain, a podcast dedicated to exploring the world of white matter. I'm your host, Anna Casal, and in each episode, we dive deep into the science behind the 60% to 80% of the human brain that plays a crucial role in its function, development, and aging. At BrainTel, we are pioneers in the measure, quantification, and normalization of white matter. We offer cutting-edge software solutions and medical devices that are transforming brain care through precise and objective data. Our mission is to bring together scientists of excellence, pharmaceutical professionals, and healthcare providers to advance brain health through impactful innovation. Join us as we discuss the latest technological and scientific advancements in the brain disease treatments and explore how these innovations are improving patient care. Brain diseases are one of the most urgent medical challenges of our times. By understanding more, we can treat faster together. Today, we are joined by a distinguished guest, Dr. Rajiv Gupta. You are an Associate Radiologist at Massachusetts General Hospital and an Associate Professor of Radiology at Harvard Medical School. Your dual role in both clinical practice and research provides you with a unique perspective on the intersection of technology and patient care. So today we're going to explore how you use DTI technology in your daily practice, the advancements of imaging technologies, and the future, I hope, of neuroradiology. So let's welcome Dr. Rajiv Gupta to the show. Hi.
Hi, thank you, Anna, for that kind introduction.
First question will be the simpler. Could you define what is white matter?
Absolutely. So that's a good question. For the lay public, the brain consists of two parts. There is the gray matter, which consists of all the cell bodies of the axons. And there is the white matter, which is all the axons themselves, which connect the different neurons within the brain. And majority of the substance within the brain, all that stuff that is enclosed in your cranium, is mostly white matter. There's a lot more to the connectivity of the brain than the cell bodies that are there. So in general, you would have long axons, which consists of like the central portion of the brain. On gross examination, they appear whiter than the gray matter, and that's where the original terminology gray versus white comes.
Okay, so imaging white matter is complex. Could you explain some of the imaging techniques used to study it and how these techniques have evolved during the last years?
Sure. So all imaging techniques of the brain will show you both the white matter and the gray matter. If you're using a cross-sectional technique such as a computed tomography scan or any sequence within the MRI. On MRI, the white matter on certain sequences would appear brighter than the gray matter, and it can be reversed because it depends on the technique. And traditionally, for the most part, we have looked at the white matter and the gray matter and just qualitatively described the pathology that we see. So, for example, there are disorders that are quintessentially the disorders of white matter. Multiple sclerosis would be one of them, where there's demyelination of the white matter tracts. There are other diseases which primarily affect white matter, but then there are also diseases which alter white matter because of the secondary effects that they have on the white matter. There are tumors such as gliomas that infiltrate the white matter and will cause mass effect by displacing the white matter. So the study of white matter is very important. And as I said, for the most part and even to date, actually, all the study that we perform, all the sequences that we perform in an MRI, kind of look at the white matter. We count the number of lesions, we count how big is the area involved, but we don't have any quantitative metrics that describe the white matter at its very fundamental level. Okay. And that is changing lately. Okay, and Braintail is one of the programs that is trying to change the paradigm by making the study more quantitative.
Okay. So can you share how Braintail team and the platform has impacted your research and clinical practice? Maybe with more details.
Mhm. Sure, sure. So I've been involved with Braintail actually, and the program that the Braintail has pioneered even before the company came into being. So I worked with the team that is behind this software for about 15 years. I was collaborating closely with PT P3A in France, and over there they had a cohort of patients in their neuro ICU. These patients with very debilitating brain trauma, people who had
Mhm.
fallen from high places or motor vehicle accidents. And we had a similar cohort at Mass General Hospital. Many of these patients were comatose, and there was essentially no clinical exam. And family wanted to know what will happen if these patients were to wake up. Are they going to survive this horrible incident? And if they do survive, are they going to be like in a permanent comatose state, or are they going to be in a minimally conscious state, or a permanent vegetative state, or would they improve better than that? That they will be able to walk, they'll be able to communicate, and so on. And using the qualitative metrics, looking at the images as I normally do in my clinical practice, I had no way of actually answering that question in a sort of a informed way,
Mhm.
in a method by which I can kind of evidence-based method of supporting that. So we asked Wansa, who is a scientist behind this software, to say, can we quantitate the white matter, which is majority of the brain, which is what is injured, sort of alters the communication between different parts of the brain, and most of the disease and the aftermath of trauma manifests because of alteration in the white matter. So he looked at something called a diffusion tensor, which is a complicated word for something relatively simple. Essentially, we're asking how is the diffusion of water molecules within the substance of the white matter altered by whatever disease entity we are looking at. In our case, we were looking at traumatic brain injury. And you can plot something called a tensor, which is the amount of diffusion of water, the degree of diffusivity in different directions. Okay, and we can expand on that. But these are quantitative metrics of the brain parenchyma. And we ask the question, if you were to divide the brain into different areas, ask the question, how is this parameter, this quantitative metric, changed in the patient that we are talking about vis-a-vis a normal cohort?
Mhm.
What information can we derive from that? And the results were absolutely astonishing.
Oh,
What
very
we found
interesting.
was that you could very precisely actually predict the outcome that this patient will have, not only immediately, but 1 year, 2 year, 5 years out.
Mhm.
So this was, to me, a very significant finding that underlies the creation of this software. That we have a biomarker
Mhm.
which is which we can derive non-invasively. It is not biased by our ability to examine the patient. We are not looking at qualitative markers of how much strength they have, whether their Binsky is reflex is preserved or not. And we are looking at the whole brain. We're not looking
Mhm.
at just one portion of the brain. And then based on that and how this quantitative metric is altered in the patient under consideration vis-a-vis the normal healthy control has a high prognostic value. It can
Okay.
predict long-term outcome. And that was to us the eye opener. And that's kind of what led to the creation of the company and the later on development of the software.
So we could say it had a big impact on your research and clinical
A-
practice.
Absolutely. So dozens of papers have come out of it. The software has been used as the main core foundational software for multiple trials on
Mhm.
both sides of the Atlantic. I've used it in my own research, and it has been used extensively in Europe at
Okay.
multiple centers.
So you spoke about a little bit about the diffusion tensor imaging, DTI. I think it has been a critical tool for understanding white matter. What do you see at its main limitations and how new technologies can overcome some of these?
So diffusion tensor I mentioned is something that is measured using gradients. You apply
Mm-hmm.
a gradient field, and based on the gradient field, you see how far the water molecule can diffuse. As a result, the number that you get, the actual quantitative biomarker that you get, is dependent on how you scan the patient,
Mm-hmm.
which hardware the patient was scanned on, and what were the parameters of the acquisition.
Yeah.
So while it has a component of underlying intrinsic truth about the patient,
Mm-hmm.
it is affected by the measurement tool. It's like having some two different thermometers. One thermometer is in Fahrenheit, the other thermometer is in centigrade. They're
Mm-hmm.
measuring some underlying truth, but these are two different scales. So something needs to be done in order to make different scans comparable to each other. A large part of the innovation that underlies the BrainTail software lies in making this calibration, which makes the comparison of this particular metric possible and consistent
Yeah.
across different time points.
Okay. So we could speak about DTI 2.0. It's a new
Yeah,
kind of DTI.
mhm,
Yeah.
that's right.
Okay. Aside from brain do you use other biomarkers in your research and how do they complement the information from white matter measure?
So, majority of the clinical work that is done, even to date, is done on a qualitative basis. So, for example, for multiple sclerosis, we will count how many lesions are there, how many, whether the lesions are getting bigger or smaller, whether they enhance or don't enhance. But we do not really ask the question how much are they affecting the underlying diffusion tensor.
Mhm.
But this is changing. There are, besides BrainTail, there are other programs. MGH, the Martino Center at MGH has developed a program called Tracula, which looks at white matter tracks. That's where the name Tracula comes from. And it also produces quantitative metrics about the alteration of the diffusion tensor. And so while BrainTail will give you what the value of the diffusion tensor for each region within the brain on a standard atlas, Dracula gives the diffusion tensor for each white matter track within the brain. Okay, so it automatically identifies 18 or more large white matter tracks which are defined, such as the corpus callosum, the anterior longitudinal fasciculus, and so on, and would give you parameters about that. Both of them are actually giving you the same or similar information,
Mhm.
except that they are giving to providing that information to you on a different template. It's like
Okay.
organizing the information slightly differently. So we have used Dracula for our research in some of the projects, in
Okay.
addition to using BrainTail.
Very interesting. So there are new tools in radiology, and this is kind of new era for radiologists, I guess. Which technology is exciting you the most, and how do they improve, in fine, patient care?
Yeah, so the world is shifting. There are newer MRI scanners that are now available.
Mhm.
And the thing about the newer MRI scanners is the increase in the field strength, which increases the signal that we get, specifically for diffusion tensor, which is based on the gradient strength that is used in the magnet. We have very high gradient strength or slew rate scanners available now. So there's
Mhm.
a scanner, for example, at MGH called the Connectome, which is very high in the amount of gradient it can apply. And what in layman's terminology it sort of provides is an ability to measure the diffusion tensor much more accurately than we have been able to do in the past. We also have ability to accelerate the scans. So earlier the diffusion tensor acquisition used to take maybe 12 minutes, but now we are able to do this in 5 minutes or 6 minutes or even faster than that. So the speed with which you can acquire the data is increasing, and the quality of the data and the precision with which we can acquire the data is improving. So these two together make a quantitative measure much more appealing than it has been in the past. So I expect to see measures of quantitative measures of diffusion tensor being used much more in a variety of diseases besides the traumatic brain injury that we have used. We have also used it for ischemia, the global hypoxic ischemia, for example, after heart attack, where there's a loss of circulation for some time, and that causes a sort of an irreversible injury to the white matter. And that injury, for example, on a quantitative measure, very different from traumatic brain injury. One is in a traumatic brain injury, the myelin is injured, and that's what you see on your diffusion tensor. While in a diffuse hypoxic injury, when the oxygenation of the brain is stopped, the neurons die, and that is what alters the diffusion tensor. And these two are distinguishable using a program such as BrainTail, which is not possible just looking at it from a sort of a qualitative way, because both of them are alterations in the diffusion tensor.
Okay,
So I
very
see more and
interesting.
more application of quantitative measures of diffusion tensor in a variety of diseases. And we can talk about other diseases where it could be possible to use such a measure.
Very interesting. Thank you. Coming back to your daily work, you balance both research and clinical practice. How do these two areas complement each other in your work and in the context of brain imaging?
Yeah, so both are very complementary. To some extent, the research questions that you ask should be grounded in clinical practice, and that's where your clinical practice sort of grounds you as to what question you should be asking. And when you are doing clinical practice, you are able to migrate some of the tools that are available in research and affect patient care and sort of advance the field and in that manner. So, for example, recently in the last 2 years, the way dementia is treated, there has been a quantum shift in that. So, Alzheimer's disease, for example, for the long time did not have a way of diagnosing it non-invasively. You had to do a brain biopsy. That changed some time ago. Now we have pretty accurate imaging methods for saying that this is Alzheimer's disease or it's not. Then for the long time, for the longest time actually, you could diagnose Alzheimer's disease, but you couldn't do much about it. There were some drugs that were some very minimally effective, if you will, but nobody could do the alter the progression of Alzheimer's disease. Last year, lecanemab became FDA approved, and now donanemab, if I'm not mistaken, has also been approved. So both of these are monoclonal antibodies that remove plaques from the brain. Fundamentally, Alzheimer's is a disease of deposition of protein in the brain. And if you have a way of removing that protein, you hope to reverse the effects of that disease. And that was proven in a large clinical trial, both for lecanemab and for donanemab. So one of the things that has happened because of that is even though the disease can be altered in some way, the progression of the disease can be altered in some way, it has side effects. So it generates a lot of MRIs. You have to watch out for those side effects, hemorrhage being one of them. But a question could be asked, what does removal of plaque within the Alzheimer's plaques and tangles within the brain do to the white matter with or without the medication? And that's a question that's an open question. You can look at the brain parenchyma in a qualitative manner and say something, but that's not as powerful as quantitatively showing that we are restoring the connectivity of the brain by removing plaques.
Okay.
And so that would be sort of hypothesis number one. Does that happen? Hypothesis number two would be it is possible that in process of removing this, that there are side effects that we are unaware of, which may be manifesting more quantitatively than qualitatively. And it'll be good to know that. So that's something that we want to do. I've talked to the Braintail leadership to sort of start a study in that area.
Really interesting. Thank you for sharing that. We have a recurring question we ask every invitee. Why does white matter matter?
Oh, that's a very fundamental question. Why does white matter matter?
Also, how will white matter in 10 years from now?
I see. So for white matter is something that is required for the functioning of the brain. If you think about the brain, for certain things we have specific areas, but for certain things, it is the whole network that matters. Okay, so the brain is able to think not because some small piece of the brain is thinking, the whole brain is thinking. And this has to do with the connectivity of the brain. So if you alter the connectivity of the brain, which is what the white matter sort of accomplishes, you just completely change the way the system works. Okay. I'll give you an example. There are individual computers. Computers have CPUs and they can do certain things. But now we have multiple computers connected together by the internet and by local area network and wide area network. And together these computer ensembles can do more things. For example, the whole field of AI has become possible because of multiple GPUs training. The way the AI operates is a neural network that sort of communicates. Now, the links within the neural network are similar to what the white matter is in the brain.
Yeah.
And if you alter the link, if a disease alters those linkages or kind of cuts those linkages, same thing will happen to the brain. So the white matter not only matters, to me, it is the brain. This is fundamental and central to the brain.
Okay. Last question. Who would you recommend we invite to this podcast to further explore the themes of white matter?
So there are multiple people. There are people who can talk about the technology behind the software and quantitative measurements. So people who can talk very eloquently about how diffusion tensor is obtained and how diffusion tensor works. There are people who talk about the fundamental technology underlying quantitation and calibration. So that's kind of more in the space of like PhD scientists explaining the functioning of the software. Then there are disease experts who are talking and researching about diseases that affect white matter. Okay, so multiple sclerosis, Alzheimer's disease, and traumatic brain injury or diffuse hypoxic ischemic injury. Both of them are sort of important. So, and there are people who are really studying disorders of consciousness. Now, disorders of consciousness have to do with alteration of the connectivity of the brain to the extent that the brain is not able to think anymore. That's where sort of the consciousness arises from. It's a distributed phenomenon. So, for example, in our neuro ICU, Brian Edlow is one person who studies the disorders of consciousness. And it'll be good to interview him for this podcast, and he can actually educate all of us about what he has found as what is the seat of consciousness within the brain. For the technology aspect of Braintel, perhaps Vincent or others would be more apropos. For general clinical use, maybe Damien Galeno or Louis Puivessin, they could talk about it. So
yeah, Louis is going to answer our questions. That's great.
Okay, excellent.
Thank you. A huge thank you to Dr. Rajiv Gupta for joining us today and for the rich discussion. Your insight into the advancements in imaging technologies and their application in studying white matter have been really, really enlightening. Thank you so much for listening to The White Side of the Brain. We hope today's episode shed light on the critical role of white matter in brain care and the innovations transforming care. Stay tuned for more discussions with leading experts as we continue to explore, learn, and work towards better treatments together. Until next time, let's keep pushing the boundaries of brain science.